And we are going to move on to the next case presentation by Wouter Yukema. Wouter, you have the microphone now. Thank you very much.
Okay, the clinical presentation that I want to share with you is a very recent case of mine. I thought 2 weeks ago, a 38-year-old female, normal weight, normal height, cardiovascular risk factors, none, no previous medical history. She does a regular sports, not very intensive, just regular. And she was admitted at 4 o'clock in the afternoon for acute chest pain lasting 40 minutes. And it just occurred while she was driving her car from her work home. It was a bit busy on the street, but not extraordinary. And then she suddenly experienced chest pain and just thought that she was just sitting wrong in the chair. But then it lasted and it lasted. And she drove herself to our emergency room at the hospital, where she had a normal clinical examination, a blood pressure of 135/76 and a heart rate of 78. Not too special. Of course, an ECG was made. And, well, I think for all of you, this is pretty obvious. You see ST elevation, especially in V3, V4. So this is what you can vote for in a call. What, in your opinion, is the most likely diagnosis for this lady? Is it a plaque rupture? Is it coronary spasm? Is it a spontaneous coronary artery dissection, the so-called SCAT? Or do you think it's a stress-related Takotsubo cardiomyopathy? Can I please have the poll? Yep, you can start voting now. So the vast majority thought it was most likely a spontaneous coronary artery dissection, a SCAT, 60%. Then we had a stress-related Takotsubo cardiomyopathy for 20%, and 2 times 10% for coronary spasm or just a regular plaque rupture. This is what you see on the angio. A right coronary artery and a right circumflex artery were actually normal. And I think that the most likely diagnosis, if you look at this picture in the LAD, that it is a SCAT, spontaneous coronary artery dissection with some intramural thrombus. It was totally occluded, so there was no penetration of contrast going, so we had to open the vessel, and you see what it looked like, the post-wiring on the right side. So if you then look at what are the ACS types, we were discussing several types of ACS and alternative causes. Well, of course, the most frequent ACS type is the top one, the thrombus formation on the ruptured or eroded plaque. That can always happen. A plaque rupture can always occur also at younger age if you have relatively little plaque, but a plaque rupture may occur. Of course, coronary vasospasm may occur as well. This lady never experienced such a thing before, so that I think it makes it less likely. And of course, then you have the spontaneous coronary artery dissection, where you have a true lumen and a false lumen, where the blood is just emerging, and a stress-related Takotsubo cardiomyopathy. This was not really stress-related, so that makes, I think, it less likely. Recently, I had a typical case of a stress-related Takotsubo cardiomyopathy. A 50-year-old lady watched her son during the World Championships golf surfing, and her son almost drowned. And he was taken with an ambulance to the hospital, and then she realized she also had chest pain, and she had a typical Takotsubo cardiomyopathy. But I do think this is most likely a SCAT. I want to tell you some more about the backgrounds of the SCAT. I rely on this, by the way, on a beautiful slide presentation made by the European Society of Atherosclerosis, published in the European Heart Journal. And SCAT, the title, refers to the acute development of a false lumen within the coronary artery wall, which actually may comprise coronary flow by external compression of the true lumen, and it may go to a total occlusion. Well, this is how a SCAT may look on angiography or an OCT. OCT may be very helpful here, as a colleague Colette already beautifully discussed. OCT may be sometimes very helpful in the cath lab. And this is also a young woman presenting with chest changes and anterior ST segment changes on the electrocardiogram. And then you see between the B and the D mark, you see a tortuous part which is clearly compressed. which will remain unchanged after administration of intracoronary nitroglycerin. And well, if you look at the OCT images on the right side, it's clearly depicting a long intramural hematoma. It's depicted in yellow with the yellow stars. There's still a reasonable lumen, as you can see, that's concordant with the angio, but there's a huge intramural hematoma. So, and this is what it's supposed to, how it is supposed to go. There are two theories actually. The bleeding can be from the inside out, or the bleeding can be from the outside in. So this is a schematic illustration of a SCAT. There can be an accumulation and actual propagation of blood forms, a false lumen in the outer third of the tunica media, leading to the external compression of the true lumen. Blood may also enter through an endothelial disruption or a tear, as depicted in B, or as a result of a bleeding from a microvessel within the vessel wall. That's depicted in situation C, leading to an expanding and compression of the false lumen. So this is all the theories that you can, and perhaps they all exist. So what's the background, some backgrounds of the epidemiology of SCAT before I go to the treatment? Although SCAT has been described across a broad demographic, it is a frequent cause of ACS in young to middle-aged women, as well as in patients with myocardial infarction during pregnancy. We see it quite often during pregnancy or postpartum. Pregnancy association SCAT accounts for a minority of cases, though, so it's certainly not the predominant thing during pregnancy. A lot of SCATs happen outside pregnancy, and also the lady we had in the car was not pregnant. So some backgrounds, I told you some already about the inside out or outside in theory. We do see that there is a strong female predisposition, and association with pregnancy also suggests a role for female sex hormones in the pathogenesis of SCAT. But actually, to be honest, the majority of the mechanism just remains unknown. We just don't know why it's occurring so suddenly in the majority of the patients. SCAT is also frequently associated with extracoronary arteriopathies, including the fibromuscular FMD. SCAT is not a strongly inherited condition, and I would say research is needed to better understand the pathophysiology of SCAT, because it's very little is known actually, and also very little is known to guide our practice, and I will come back to that later. Patients with a SCAT usually present with an ACS if they present, and delayed diagnosis is pretty common, and SCAT should be actively considered in the differential diagnosis of an acute coronary syndrome in considered low-risk patients. So then what to do? Well, then if you know what to do, you go to the trials. You need the evidence from the trials, I will always say. The proof of the pudding is always in the eating. The problem is here, there are no trials. So this is always cumbersome, of course. So we have to do what we think is best, and with some circumstantial evidence, and there is some circumstantial evidence. So the management of the SCAT is the coronary revascularization is actually associated with an increased risk of complications. You see more or less propagations of the thrombus when compared with atherosclerotic coronary disease. So it's more difficult to treat it with a PCI. And a conservatively managed SCAT, so without a revasc, usually heals completely within a few months. It just disappears completely. So if flow is maintained, and in the absence of ongoing ischemia or infarction, probably a conservative approach should be considered, and it's probably best followed by a period of inpatient observation. And if there's ongoing ischemia of the occlusion of the blood vessel, further research is needed to clarify the optimal PCI strategy in cases where the revasc is necessary. An acute and convalescent medical strategy in SCAT may have key difference from a post-atherosclerotic acute myocardial infarction. Perhaps you should just treat it differently, and further research is therefore really needed. I just want to show you one more example next. Here you see an anterolateral branch with a typical SCAT-like intraluminal hematoma, and a balloon angioplasty was performed, and a long stent was placed. And what you then see on panel C with the arrow, that actually the stent is in place, but that the hematoma has just progressed to more proximal. And if you then keep on stenting, you may end up in the main stem finally. So you should be careful. I do not want to say you should never stent, but you should be careful with your stenting. So last poll, lipid lowering medication in SCAT. What would you advise after the lady I presented to you, who had just the sudden complaints in the car? Would you consider to give her 1 maximum tolerated statin dose? 2, you think you're not convinced by the atherosclerosis, you'll only give a low dose statin or ezetimibe therapy, monotherapy? Or would you think, well, this is just an ACS, so keep to the guideline, put a statin and PCSK9 inhibitor if LDL remains high? Or would you start continue lipid lowering medication only in the presence of clear cardiovascular disease, atherosclerosis? Can I see the poll? Okay, you can vote now. Well, you can easily imagine, because there's very little evidence, so you could argue that every answer is correct. You say, okay, you could say maximum tolerated statin dose. That's the most prominent one, 35%, because you say, okay, but this is a myocardial infarction and atherosclerosis may be an important part of it. We don't know. Low dose statin or ezetimibe is clearly the least popular. Then we have the most aggressive approach, which is 27%, but exactly also 27% is start continue lipid lowering medication only in the presence of cardiovascular disease. For this lady, I didn't show you all the details. We had no evidence actually that she had cardiovascular disease. On the OCT images, we could not find any atherosclerosis, so we thought probably she had no other cardiovascular disease and there were no other signs of atherosclerosis. So what is our approach to do in such patients? This is not a universal approach. This is not what you absolutely should do, but this is what we then in general do. So when stented, we start DEPT according to existing ACS guidelines. If not stented, then probably the best thing is to start as a aspirin monotherapy, and you should only continue it after 1 year if there is clear presence of atherosclerotic cardiovascular disease. So 1 year of ESA and nothing more. Stop low molecular weight heparins, because probably there's a higher chance of intramural hematomas. Some argue that you should start a beta blocker in a perhaps low dose, because it is reported that a rescat, which may happen, is prevented by beta blockers. The general recommendation by us, taken from the ESC, is start continue lipid lowering medication only in the presence of atherosclerotic CVD. So if you have no atherosclerotic CVD, then it's probably not very useful to give lipid lowering to young ladies, for instance. And start heart failure medication in the presence of reduced left ventricular ejection fraction according to the guidelines and not routinely. And check for other arteriopathies like the FMD. So that concludes my presentation on the SCAT. So I hope you enjoyed it. And if you have time, visit Leiden. This is a windmill close to Leiden, actually, with the bulb flowers. And I do hope that you enjoyed the Netherlands then, and as you enjoyed the presentation. Thank you for your attention.
Okay, thank you very much, Wouter. I think this cases was much needed in the ACS forum. We have lots of questions for you. So if you can give short answers, we may answer all of them. First question. We understand the role of OCT to make the diagnosis, but is it safe to do OCT in all these patients when you see sometimes very long narrowing of these arteries?
I think this is an excellent question. I think it is not, first of all, it's not absolutely necessary to do ACT. You should not feel obliged to do it. What is very nice, if you are really in doubt that you can do it, and if you think that it is feasible for this person without too much danger, you can do it, because you can see the intramural hematoma, you can see if there is yes or no atherosclerosis, so it may help your future therapy. But of course, it may be, it's like any intervention, it may be dangerous. So it's not a must do, but if you think you can perform it safely because it looks reasonable, if you look at the blood vessel, it may be a help.
Okay, thank you. A question from Janine Reuters van Lennep. Do you know at which phase of the menstrual cycle the SCAD occurred? It has been described previously that it can be related to menstruation.
Yeah, that is what I know as well. But to be honest, I'm not aware of any details, and I think it's pretty vague. Well, it clearly, you would expect that when your estrogen is on top, you should have like a pregnancy. It's the most frequent, but I'm unaware of very large series that are actually proving that it's a certain phase of the menstrual cycle. Perhaps Janine knows it herself.
Yes, one other question
There are only case reports described, but there are no large series. And
Okay.
that's also because, well, quite a lot of cardiologists forget to ask.
Yeah, okay, we agree.
Okay, one other question here. What about using a cutting balloon to freeze the hematoma in these coronaries?
To be honest, that's the last thing I would do. The cutting balloon, of course, really makes incisions, and you may just make the clotting, the hematoma bigger, and it's still a balloon, so you may propagate the hematoma proximal or more distal. So you would say, okay, it could relieve it, but I wouldn't dare to.
Okay. One question from Jean-Philippe Collet. What about sport activities after recovery? What do you say to your patients?
Yeah, that's a good question. I hope colleague Collet knows it at least as good, because he is he's a co-author on guidelines on physical exercise after a myocardial infarction in the European Society guidelines. I think in the beginning, I always say, okay, keep a bit quiet and just behave normal. And afterwards, you can just gradually build it up. There's no clear relation with physical exercise with this problem. So, but actually, it's what I tell every patient. I say always, we say sporting is healthy, but that's the question. Moving is healthy. So we should walk far more. We should, in the Netherlands, we should be on the bicycle. So keep on moving, but intensive sports is perhaps not the ideal, not the ideal thing. And otherwise, perhaps colleague Collet can comment on this.
Yeah, this is an issue, but as you outline, beta blockers are very important here, and probably you may control sports activities if maximal treadmill test is obtained without any symptoms. But this is also an issue, for example, for pilots, because usually it's young patient disease, and the issue is whether they can work again, and this is a complex situation.
Yeah, I agree.
Okay, Wouter, if you can answer by yes or no this last question. What about genetic testing? This question has been asked 3 times.
Yeah. The genetic background of this is pretty much unknown, and it's the hereditary part of this is also not very large. So I'm unaware of, unless you have a clear arteriopathy in the family, as I indicated, or signs of arteriopathy, but I don't think for the moment routine genetic testing is mandatory. No.
Okay, so no genetic testing, no cutting balloons. Thank you very much, Wouter.